Hello, and welcome to Advancements in Prostate Cancer as it relates to the Advancements in Urology, an AUA-JUA symposium. The AUA strives to offer outstanding educational courses and greatly appreciates your evaluations and general feedback so that we can continuously improve our programs. The AUA is accredited by the ACCME and designates this enduring material for a maximum of 1 AMA PRA Category 1 credits. Course evaluations and CME credit will be administered electronically on AUA University immediately after the course. Evaluations are very important, read carefully by faculty members, and are used for our ongoing needs assessment in selecting course subjects and faculty for future meetings. As we at the AUA continue to develop virtual education that meets your needs, we especially welcome your feedback regarding both the content and format following this program. All persons in a position to control the content of an AUA educational activity are required to disclose to the provider all financial relationships with any commercial interest. Please visit AUA University to view faculty, education council, and COI workgroup disclosures. The AUA would like to thank Astellas and Pfizer, Inc., and Janssen Biotech, Inc., administered by Janssen Scientific Affairs, LLC, and Merck & Co., Inc., for providing independent educational grants in support of this activity. You are prohibited from using or uploading content you accessed through this activity into external applications, bots, software, or websites, including those using artificial intelligence technologies and infrastructure, including deep learning, machine learning, and large language models and generative AI. Coding advice given during presentations are the opinion of the presenters and may not have been vetted through AUA for accuracy. Please verify accuracy prior to reporting on medical claims. Finally, I would like to introduce and extend a special thank you to our course director and moderator, Dr. Kristen Scarpato, for her time, talent, and expertise in developing this program. Dr. Scarpato is an associate professor of urology at Vanderbilt University Medical Center, where she completed a fellowship in urologic oncology. She is the program director for the urology residency and the vice chair of education for the Department of Urology. Her clinical and research interests focus on the diagnosis and management of prostate and bladder cancers. She is dedicated to improving medical education and mentoring trainees. I will now turn the course over to Dr. Scarpato.
Hi, welcome everyone. Pleased to be here tonight with two awesome guests talking about advanced prostate cancer. This is one part of a three-part series focusing on urologic oncology, and this is based on a needs assessment. We, the AUA, are collaborating with the JUA, Japanese Urological Association, to put together these high-yield sessions for your education. So our learning objectives tonight are to recognize and characterize the different disease states of advanced prostate cancer, describe the role of combination therapy in patients with advanced prostate cancer, and then look at the role and potential implications of genetic testing for patients who have advanced disease. Now it's my pleasure to introduce our two subject matter experts tonight. All the way from Miami, we have Dr. Chad Ritch. He is a colleague and friend, a urologic oncologist who specializes in prostate cancer. And then all the way from Japan, we have Dr. Sugimoto, who is the chairman and professor of the Department of Urology at Kagawa University in Japan, also a world expert in prostate cancer. Thank you both so much for joining tonight. Or I should say this morning. It's morning time in Japan.
Yeah, yes.
Thank you.
All
I'm
right.
very happy to be here with you all.
Well, great. Thank you. So we'll start with our first segment, which focuses on defining advanced prostate cancer. there are a lot of terminologies thrown around and a lot of different definitions when it comes to advanced prostate cancer. So let's kind of describe what is included under the umbrella of advanced prostate cancer, and then focus in on how a patient may present with advanced prostate cancer. So Dr. Ritch, can you take us through the AUA guideline definitions of what it means to have advanced prostate cancer?
Sure, thanks. And thanks again for having me. So I think this is one of probably the most important take-home points from this whole lecture series or talk is how we categorize patients and how the AUA guidelines does. And I think it takes it through very sort of pragmatically, the different states, starting from biochemical recurrence after exhaustion of local therapy. So if you think about, in your clinic, oftentimes, we would have done a prostatectomy. You see a patient who has now come back with a rising PSA. So that falls under the Advanced Prostate Cancer guidelines. What do we do with these patients with biochemical recurrence, again, after local therapy, or they may have had radiation therapy and they're coming to see you as a urologist. Then from there, you'll progress, if you have a patient with metastatic disease, you have to differentiate, is it hormone sensitive or is it castrate resistant? So then the next state is metastatic hormone sensitive prostate cancer. So those are patients where they have, visible disease on imaging, either a CT or a bone scan, but they haven't received they may have received hormone therapy previously, but, they don't have castrate levels of testosterone. And then after that, the next disease state that is in the AUA guidelines is if you have non-metastatic castration-resistant prostate cancer. So these are patients who, for example, they've had ADT or been on hormone therapy for a while. They do not have visible metastases on imaging, but their testosterone is castrate, and then their PSA continues to rise. So those are patients who are M0 or non-metastatic castration-resistant. And then the more advanced cases that we see, and these are the ones that, the management can be a little bit more complex. And when you talk about different therapies coming into play and different combinations of therapies, so metastatic castration-resistant prostate cancer, that's the next sort of echelon of the grouping. So those are the different disease states that all fall under the Advanced Prostate Cancer guideline. One other quick comment just to make. When you're looking at disease states, it's important to think about things like burden of metastases. So if you have low or high volume metastases, and high volume typically is what they consider if you have greater than or equal to 4 bone mets, or if you have like visceral mets, and at least one of those mets is outside of the axial skeleton, then you'd be classified as high volume, and that would be, different implications for management. So those are kind of everything wrapped up in a nutshell for how the AUA sets it up.
Thanks. That was a great overview, and really important, as you said, to characterize and classify where your patient falls in each of these groupings, because how we manage them depends on their classification. And biochemical recurrence after exhausting local therapy, I think, is one of the most controversial areas. There's not a lot of great data yet on how to best manage those patients, and there's certainly emerging data about them. A lot of excitement for the metastatic hormone sensitive patients. We have so much in the past decade. It's hard to believe it's been a decade now since some of the big data, Charted and Stampede, came out. And since that time, it just seems to continually be evolving. And we'll talk about treatment intensification. And then metastatic or non-metastatic castration-resistant disease, as you nicely highlighted. I think advanced imaging has really kind of changed all the spaces, but particularly that space as well. And there's so many exciting developments there, novel therapies and precision medicine when it comes to, again, genetic testing and how that may impact our patients' treatment options. So thank you for that overview. Dr. Sugimoto, can you talk to us how a patient may progress through the different disease states versus presenting kind of de novo metastatic and what the implications of that are?
Mm-hmm. According to in Japanese condition, in Japan, unfortunately, PSA screening is not enough yet, because the Japanese government has taken a position against PSA screening. Maybe same condition in US, right?
Yeah, there was a recommendation, you're right, against kind of widespread screening. And we are seeing kind of the implications of that now. The recommendation has since changed to a grade C from a grade D, but we are seeing more patients with metastatic disease, and that may be part of that.
That as a result, the rate of the metastatic disease at diagnosis is relatively high in Japan, about 15 to 17% of the newly diagnosed prostate cancer. That may be US less than 10%. It's a big problem in Japan. And more, the Japanese urologists like or love hormonal therapy, especially CAB, using a vintage bicalutamide, anti-androgen agent, even for the localized prostate cancer. As a result, maybe it is assumed that the many M0 CRPC patients are produced. The AUA guideline clearly mentioned that they should not offer the first generation anti-androgen, but in Japan, a very different condition. Yes. And because the follow-up after radical treatment for localized prostate cancer is very careful and frequent in Japan. So metaclonus MCSPC is very, very quite rare in Japan.
Okay.
In my practice, my hospital is University Academic Hospital. The patient of the biochemical recurrence after radical treatment are most common in my clinical practice. Okay.
Yeah, that is quite different. I would say in my practice, although I do think I'm seeing more patients with de novo metastatic disease, the majority of patients that we see with advanced prostate cancer, and Chad, you chime in here, are ones who have progressed through prior local therapy.
Yeah, I was sorry to jump in, but I was going to say the same here. I think probably more I'm seeing patients who had local therapy, and definitely in that biochemical recurrence space, they had local therapy, or they have, metastatic progressive disease. We try, so, obviously because it's becoming more complex to manage metastatic patients, when they come into our system through the cancer center, we try to probably more often than not prioritize them seeing the medical oncologist and then seeing us, kind of afterwards. So, they'll often see them before they get to us, the medical oncologist. But definitely the biochemical recurrence after local therapy failure are the ones that we see a lot of. We do have, as you know, Kristen, some of the patients enrolling in the SWOG trial for local therapy, in patients with metastatic prostate cancer, hormone sensitive. So, for example, those patients will come and see me first. So those are obviously, more likely to be de novo patients because they can't have local therapy, in order to be enrolled. So those are the kind of patients that I would see.
Yeah. And, I think it's been evaluated how those patients may respond to therapy. And is that different? If you're someone who's progressed through prior local therapy, does that mean that you had some, biological change or mutation that makes your disease more aggressive, and so you're going to do worse? Or is it the patient who presents kind of out of the gate with more advanced disease? And I think we'll talk in a bit about how some of the studies focus on patients who have de novo metastatic disease and how they do well with certain therapies up front. And I think to your point earlier, Dr. Ritch, maybe it's volume of disease that is most important when you're considering all factors. Maybe it's not de novo versus progressive. We certainly know that volume of disease is really important in determining what therapies to use for our patients. So let's now get into some of the therapies and talk about combination therapy. So, a lot of change in this space, and I don't want to steal your thunder, Chad, but no longer is ADT monotherapy something that is recommended. I mean, there are select scenarios where we may use it, but talk to us about kind of how that's changed and what combination therapies we're using and why, and kind of where we're at now.
Yeah, I know it's tricky, right? Because in the last 10 years, all of a sudden we have a lot more therapies, and Dr. Sugimoto mentioned, combined androgen blockade, where you give, Eligard, Lupron, or what have you, whichever ADT of your choice, and then you add bicalutamide or something else, and that was pretty much it. And then the thought of just giving someone Lupron or LHRH, agonist right now is sort of fallen by the wayside. So that monotherapy of ADT, which as urologists we're all very accustomed to doing, is not really the standard. So this combination therapy, when we're using either chemo or in some cases chemo plus a novel hormonal therapy plus ADT, all these things combined is starting to become at the forefront. So for example, if I see somebody in my clinic who's referred in with either metastatic or being treated elsewhere and they're just on ADT, I almost always put them on something else or make sure they see the medical oncologist who put them on something else. In thinking about where potentially monotherapy would be okay, I guess generally if there's a patient who, let's say you have somebody who's got another malignancy and they're actively being treated with immunotherapy, perhaps they're on pembrolizumab for metastatic RCC, and they unfortunately also happen to have metastatic prostate cancer, could you just keep them on the ADT and maybe leave that? I know it's not standard of care, but that's somebody who maybe say, based on their competing risks and trying to balance toxicities of therapy, you just keep them on ADT alone. Or if you have somebody who's truly sort of frail and elderly and unfortunately has metastatic prostate cancer, has a bad performance status, maybe in that situation you can use monotherapy. But by and large, those are not common scenarios. So you really want to try to add something else to it. So we know from Charted and Stampede that you can do chemotherapy plus ADT for metastatic disease. We also know that abiraterone and ADT is also an option. And I think Dr. Sugimoto is probably going to talk to us a little bit about triplet therapy, but combination therapy is now considered pretty much the standard for these patients when they present.
Yes, absolutely. And I think to share another scenario where we're using monotherapy can be for patients who have been managed with monotherapy for a long time, and then they either transfer care to us or they have kind of committed to that track. They're doing well. They're not having that many side effects, or PSA is undetectable. And then we say, hey, we have this new data that shows a survival advantage, and they're not overly excited sometimes to rock the boat there. But in general, combination therapy is absolutely the way to go. I want to just backpedal a second and talk about the fact that prostate cancer, we know, is a hormonally active disease, and that's based on work from Huggins and Hodges.
Huggins, yeah. Huggins.
Yes, thank you. Huggins and Hodges, H&H, from quite a while back. And so we use that as the backbone of therapy. What I'm actually seeing more in our practice here now is, rather than Lupron, we're either using Orgovyx, or many patients are agreeable to bilateral orchiectomy. And actually, one of my colleagues here has stopped referring to it as orchiectomy because it went from kind of traditional simple bilateral orchiectomy to epididymis sparing to kind of actually like just coring out the inside of the testis and leaving the tunica. And patients cosmetically kind of have a favorable outcome, and they are happy not needing to take a pill every day or not needing to get an injection every few months. What is the primary mode, Dr. Sugimoto, of androgen deprivation in Japan or in your practice?
Yeah, usually using LHRH agonist.
Okay.
Yeah. But simple surgical castration is very, very rare. All the patient and live far from hospital. And the program of the medical cost. Yeah, surgical castration is the cost is very low.
Mm-hmm.
It's very advantage point. Yeah.
Yeah. What about you, Dr. Ritch?
Yeah, I mean, same here. I think we primarily use LHRH agonists, and as you know, with the mechanism of action, you do an agonist, you do get a flare, so you have to put them on bicalutamide for a week, is what I typically do leading up to starting them on it. So in certain cases, if you really want to get somebody started, you can use the LHRH antagonist, because you can drop the testosterone pretty quickly within 24 hours, because now you're blocking directly the LHRH at the pituitary level, and so you don't get that flare. I think orchiectomy is great also. We probably don't do enough of it, and there's certainly some patients who there's added, I guess, quality of life and financial toxicity, if you will, of having to come find a family member to take their 80-year-old grandfather to get a shot of Lupron, when if you just gave them an orchiectomy, they probably would be fine. I guess the only thing with the orchiectomy I sometimes wonder and think about, and I know there's studies actually looking at stopping ADT in some of these patients who've responded amazingly well and have been sort of NED for years, and just stopping everything altogether. Thing is, if you have an orchiectomy, then obviously you can't stop that. But certainly I think LHRH agonist is what most of us use here primarily.
Yeah.
Yeah,
Can I talk?
of course.
Yeah, same as Dr. Ritch, and we usually use LHRH antagonist for the patient that need the oncological emergency, for example, the spinal cord compression and so on.
Mm-hmm.
Yeah.
Yeah, and we're now getting it approved, the antagonists, especially Orgovyx, for patients who have any cardiac history. We know from the HERO study that there were fewer cardiac events in that cohort, which I think brings me to talking about side effects for a second, since we're focusing on androgen deprivation therapy now. How are you both counseling your patients about the side effects associated with ADT therapy in any form? What are they going to experience, and what are you using, if anything, to kind of combat that?
Sure.
Dr. Sugimoto.
The ADT side effect.
Yes, sir.
Yeah, it's I think the most frequent side effect is a hot flush. Hot flush is a very serious for some patients. In such a case, we usually use a herbal therapy. Chinese herbal therapy.
Yeah. Okay.
It's good for the hot flush. And another big complication is for the long time ADT, the bone health, osteoporosis.
Great.
So,
yep.
Yes.
Dr. Ritch?
Yeah, I mean, it's always just like you said, the hot flashes are the things that stand out the most for a lot of these patients. So, you start them on it and they start to complain of hot flashes, and there are things you can try to tell them to do to help, navigate. I tell people, like, go in front of the fan or stand under the AC. It's going to go away after a while. For the folks who really have issues with them, I've tried venlafaxine as, a possible treatment, and then of course you can try Megace, but then there's a concern about cardiovascular issues with Megace to combat those hot flashes. But then there's some other things that I counsel patients on, and I don't know if it's a good or bad thing, but obviously, not to say it's a stereotypical what you see on TV, but Miami, a lot of people are very conscious about being at the beach and their bodies and working out and all these things. And when you explain to some of these men, some of whom are younger, that they're going to have increased, fat mass, loss of muscle mass, even things like obviously decreased libido, erectile dysfunction. All these things, are very concerning to them. So, as best as you can, you try to reiterate that, if you're on ADT, try to watch your diet, see your cardiologist if you have one, or your primary care doctor. Make sure blood pressure, blood sugar is okay, because you can also get those changes in your lipid profile and your sugar, blood sugar. So a lot of these things are like, lifestyle balance and figuring out how to keep people active enough and aware and conscious that some of these things may change. Because it's not uncommon. You'll have a patient who comes in and their, blood pressure is like 160 over 100. And they're like, I don't know what's going on. I must be stressed. I'm here for my shot. And you're like, it's been like this for a while, maybe it's the ADT. Or they may say something like, yeah, my primary care doctor is telling me that my, cholesterol is high. And as urologists, we're not thinking about cholesterol because it's obviously, primary care. But when you're on ADT and you hear the patients like bringing up these things, obviously you have to stop and say, wait, is it the ADT? Now, we can't necessarily stop the ADT if they have metastases, but you want to start thinking about counseling them about, changing their medications, or maybe even picking up the phone and calling the primary care doctor and say, hey, just a reminder, he's on ADT, he's castrated, he may, have issues with his lipids and so on. So I think a lot of that, primary care world that's not so familiar to us, we have to kind of refresh our memories when we start people on ADT.
Yeah, absolutely. And you bring up an important point about multidisciplinary care. Certainly for patients with advanced prostate cancer, we're managing multiple medications, and they're on medications for other comorbid conditions, and there can be drug-drug interactions. There can be just a lot to manage. And so in the name of great patient care and most favorable outcomes, multidisciplinary approaches to these patients is really important. And so, oncology, cardio oncology, radiation oncology, certainly our medical oncology colleagues, primary care. And I think like to think of us urologists as kind of quarterbacks of the care, but as long as everyone's on the same page with the patient, I think that you can optimize outcomes. I just want to make one more point about side effects from ADT that we're learning a little bit more about is the cognitive impact of androgen deprivation therapy and associations with dementia. And I think already in an older population who may already be kind of predisposed or, polypharmacy, I really worry about it. And so I'm anxious to learn more about it. We're seeing more in the literature about the cognitive decline. And I think patients and their families and caregivers need to be aware of that as an important side effect. So let's talk about patients in that metastatic hormone sensitive group or bucket. Dr. Sugimoto, there was some recent exciting advances about treatment intensification or triplet therapy for these patients. Can you talk us through some of that information and how we should be treating, or which patients we should be treating with triplet therapy?
Yeah, triplet therapy, the ADT plus NHT plus dose, is emerging recently with a solid evidence, PIS1 and Astellas. The PIS1 is a 2x2 designed study using docetaxel, bilateral, and local radiation therapy for M0 From this study, it is revealed that the ADT plus dose plus RB triplet treatment is superior compared to the ADT plus dose doublet treatment. The Astellas trial is also triplet clinical study using ADT plus dose plus darolutamide compared to the ADT plus dose. The Astellas also show the triplet therapy using NHA is superior to dose doublet. From both studies, the message is no more dose doublet. In the case of using dose, should be coupled with NHA. But in Japan, the darolutamide triplet is approved, but abiraterone triplet is not approved yet by public health insurance. Maybe I think the triplet therapy is indicated for the young patient, and maybe Gleason score, high Gleason score, and visceral metastasis, and so on. That's all. Thank you.
All right. No, thank you. So triplet therapy with either abiraterone or darolutamide in combination with ADT and docetaxel. And I think the take home that I have as well is that this is probably best for patients who have de novo high volume disease and patients who can tolerate chemotherapy. So as you said, survival advantage. So there's a radiographic progression-free survival advantage, an overall survival advantage, and then other important endpoints that we see in many of these prostate cancer studies, like time to development of castration resistance or need for additional systemic therapy, or even like bone-related events. So it's pretty remarkable. Dr. Ritch, any thoughts? Are you guys using triplet therapy, and how are your patients doing? Any adverse events that you are seeing?
Yeah, so we obviously, just like everybody's been using it more and more because of the noted advantages, survival, progression-free survival, radiographic progression-free survival. I think the scenarios where we kind of pump the brakes a little bit is, you have the patients that are bleeding and they're obstructed and they're in and out of the hospital, and you have to maybe TURP them and they're anemic, and you're worried about maybe if you give them docetaxel on top of that, if that's going to push them over to be a little bit more anemic than usual. Until you address the bleeding, holding off on it then so you don't do the full triplet combination. But I think for the most part, if somebody's performance status is good and they're generally, asymptomatic, but they have high volume disease, those are the patients we're trying to hit with everything. So full triplet therapy for them.
Yeah. And, I don't think, as long as they're chemo fit, it doesn't appear that the side effect profile for these patients is prohibitive. They seem to be tolerating it well and then doing okay from the cancer standpoint, or doing better from the cancer outcome standpoint. So really exciting developments.
Yeah. And I think, sorry, one other quick point I was going to
Yeah.
make is, when we first, remember when abiraterone came out and everybody was kind of like, oh, I don't want to prescribe this because then you get the mineralocorticoid excess and you have to do prednisone and managing that. And then now we see that it was actually quite well tolerated. Most patients handle abiraterone pretty well, and even us as urologists can manage them, fairly well. And then putting chemo on top of it, they don't do necessarily any worse, maybe a little bit more fatigue, but I think that the triplet is really well tolerated in general.
Yeah. And Dr. Sugimoto, you were saying that abiraterone is not approved as part of triplet therapy, or for...
Yes.
Okay, but you're using it in combination therapy.
Yes, only darolutamide triplet therapy is approved in Japan by public health insurance.
Okay, but in in looking at triplet therapy, or is that the only novel hormonal agent that is approved?
Yes.
Okay.
Yeah, only darolutamide, yes.
All right, and that tends to be well tolerated.
Very well tolerated. Yes, in Japanese, for Japanese, maybe no problem.
And I just had a quick question for Dr. Sugimoto. So if it's covered for all patients across the board, it's paid for by the government, darolutamide?
Yeah, darolutamide. Yes.
That's great.
We need to take a page out of that book.
I know. I learned something very new and important today. That's great.
Yeah. So, Chad, are there patients, when you have a patient in front of you and you're trying to decide between which novel hormonal therapy you're going to use in metastatic hormone-sensitive disease, and they're not someone who you're considering triplet therapy because they don't have a high volume of disease, let's say?
Yeah.
How are you deciding between abiraterone and enzalutamide or apalutamide?
Yeah, I think mainly, well, insurance is one thing, whether we're going to get one thing approved, versus another. And I tend to see, abiraterone seems to be a little bit easier to get covered than the other medications. But that being said, if somebody is like a heavy drinker, or somebody who has concerns about liver toxicity, then I may avoid abiraterone. Or, if they've had really bad high blood pressure, or if they have CHF, and it may tip them over if they come in and they look kind of like they've got a lot of leg swelling, fluid issues, I may avoid abiraterone in those cases, because again, with the mineralocorticoid excess, you can get worse side effects in that regard. So you can get liver toxicity, bad hypertension, sometimes can cause CHF. So then I would use something like enzalutamide, or apalutamide is another medication. Deciding between enzalutamide and apalutamide to me is, they're kind of the same. I'm sure there's probably some sort of nuances there that some people prefer, but I usually kind of see those as kind of similar in those regards.
Yeah, and I look at it much the same. If someone were to obviously have a history of seizures or have some significant fatigue, and layering enzalutamide on top of that may not be something I want to do, or as you said, cardiac comorbidities or, brittle diabetics, and you're not interested in adding a steroid. But otherwise, patients do well and tolerate it, and it's kind of insurance and dealer's choice and experience there.
Can I talk?
Yeah.
About the apalutamide, in Japanese, for Japanese, the skin rash prevalence is very very common adverse event, very serious adverse event. In the clinical trial, in global cohort, about 30% skin rash, but in Japanese cohort, more than 50%.
Oh, wow.
Very common adverse events. It's very serious point.
And it's to the point where they have to stop the therapy. It's like that.
Yes. Sometimes systemic steroid therapy is needed.
Yeah, so half of the patients end up with a rash.
Yes.
That's like almost double what it was in the trial.
Yes.
Has anybody studied the mechanism or tried to see why?
Yeah, there are no definite mechanism is elucidated, but low BMI, low body weight is one of the reasons.
Well, that's a good segue into talking about diet and lifestyle and how that may impact cancer outcomes and how you counsel your patients. And so Chad and I are just going to both agree right now that you are way healthier than we are and more physically fit. And I'm sure all your patients are too. So how do you talk to your patients about diet and lifestyle? So many patients I find are asking about it and what can I do to help my cancer outcomes? What should I eat? What should I not eat? What do you tell your patients, Dr. Sugimoto?
Yeah, basically no limitation. But the most important, I always talk the patient. You should keep your body weight. Yeah, it's body weight and the exercise. Keep on the physical examination, physical exercise, or keep on the job, sports. Golfing, running. The only important thing is keep a body weight. That's all.
Yeah.
And what about you, Dr. Ritch?
Yeah, no, I agree. And yeah, to reiterate what Dr. Scarpato was saying, like I was telling Dr. Sugimoto many years ago, I did a study abroad in Tokyo, and I just was amazed at like how fit and like everybody seemed to have the same BMI versus in the US, it's like you have a much higher BMI, so concentration on fitness and exercise is a challenge, and dietary changes. Now, a lot of patients, when they get the awakening of, they've got metastatic prostate cancer, they're on therapy, they're willing to take up the challenge. But yeah, I mean, a Mediterranean diet, heart-healthy diet is what I tell most people. Smoking is an issue as well, so I tell people stop smoking. And then, with osteoporosis, if you do some weight-bearing exercises, maybe that can help to, slow the stem of osteopenia to osteoporosis. So those are kind of the things I try to reiterate, but it's tough. I think all the patients kind of look at me and roll their eyes when I tell them, oh, you need to go to the gym more. And they're like hot flashes and fatigued. And, they're like, what do you think I do all day? So it's tricky, but I think that's what we have to encourage them to do.
Yeah. I always have said, like you kind of led off with, Chad, that heart healthy or a Mediterranean diet is the way to go. And so my line always used to be, a diet that's healthy for your heart is healthy for your prostate. And I still believe that. But the data that shows a benefit for prostate cancer patients, either in the prevention setting or doing better when they already have a diagnosis, that plant-based diets may favor, may be more favorable in terms of outcomes for those patients. I think being totally plant-based would be very challenging for most people, and so not something that I recommend, but I say plant forward. So trying to eat as much kind of green leafy fruits, vegetables, plant-based foods, in addition to healthy proteins, is good in terms of limiting inflammation. So, avoiding processed foods, avoiding foods that are high in saturated fats, things like that we know can be kind of cancer promoting and can contribute to an unhealthy weight, are things that I encourage patients to avoid. And then, as you both said, physical activity. And I tell patients before they start therapy, if I'm meeting with them then, or if they're already on therapy, really try to encourage them and their partners or families to stay active. And walking is exercise. Not only is walking good for your heart and your kind of stamina, but I think it gets most people outside, which is good for the soul. And any little thing can help. They don't have to go and crush, the erg or, lift really heavy weights. I think being active can be as easy as taking a mile walk or, swimming or riding a stationary bike. Good for the bone health too.
And you get sunlight.
Sunlight, yes. Miami. It's kind of failing here now, so we won't talk about sunlight. All right, well, let's segue now into talking about genetic testing for patients with prostate cancer. This is another area where we've just seen rapid development, change in guidelines, and a lot of new recommendations that can benefit patients and their families when it comes to genetic testing. So, Dr. Sugimoto, what is recommended right now in Japan in terms of genetic testing for prostate cancer?
Yeah, in Japan, in JUA guideline, the genetic examination is carried out at the CRPC patient, not so early stage. I think it's a big problem. That in NCCN guideline, the early stage, even for the localized prostate cancer, the genetic test is recommended. It's a big difference between the US and Japan. Yes.
Is it covered by insurance?
Yes.
Okay, good. And Chad, what about in your practice, starting with localized or early stage patients? Are you incorporating genetic testing?
Yeah, so admittedly, I don't do much genetic testing myself. And again, we try to keep it multidisciplinary in the sense that pretty much all of our metastatic patients will see the medical oncologist and they do a lot of that testing, or we send them to genetic counseling and they will order the testing. I mean, I can think of maybe a handful of patients who I do it in, and it's not because I don't believe in it or I wouldn't do it, because the guideline says if you have a patient with metastatic hormone-sensitive prostate cancer, they should get germline genetic testing. But I think in our cancer center sphere, the medical oncologists do a really good job of that already, and they're sending their patients. They also do a lot of the somatic tumor testing. So, if we have the tissue samples of them, they can go ahead and do the testing on that as well.
Yeah, so just to kind of go over some of the basics again, somatic and germline are different tests, and germline mutations refers to a mutation that you're born with, you inherited and found in every cell in your body, and you can have that tested with a blood test, or it can be based on a swab of your oral mucosa. Versus the somatic testing, which is tumor tissue, can be obtained from the prostate itself, or it can be from a metastatic site. And there may be some overlap in the mutations that are detected, but they are fundamentally different tests. I think one of the kind of issues with widespread adoption here, and maybe too in Japan, is a kind of lack of familiarity with genetic testing among urologists, which is definitely improving. But this idea that we need genetic counselors and there are not enough genetic counselors and therefore we can't order the tests. But I really believe, and I think many now believe, that it's okay for us to talk to our patients about what genetic testing means, what are we looking for, and then what are the implications of it. And if the test comes back negative, great, I can call you and tell you that the test is negative. But then if the test comes back and says there's a variant of unknown significance, or there is a particular mutation, a BRCA1 or 2 mutation, then you see a genetic counselor who is way smarter than I am, who can tell you all the things about that. So I think that that's kind of what we have set up in our practice. And many of the tests, the companies themselves offer some genetic testing to patients for free.
Oh.
So go ahead.
Oh, I was just going to say, another thing with the genetic testing that I think adds value is, I mean, the rate of, finding a mutation, if you look at the literature, is probably like 10 to 11% or something like that have mutations. But overall, if the more people you do germline genetic testing on, is the more data we'll have to start detecting some of these variants. Because at the end of the day, there are people like, you've seen them, I've seen them, family members who have had multiple people with prostate cancer, bad prostate cancer, and you order a test and then nothing shows up, and you're like, how is that possible? It's probably that they haven't detected that pathogenic variant yet. And the more people that do it, as these tests become more sophisticated and sort of recalibrated, is the more that number will go up from 10% to a lot higher. And I think that's the added value of doing this testing, we as a field.
Yeah, that's a really good point. And you brought up percentages and what we expect in terms of finding mutations in the general population. There was a paper that came out fairly recently, published in the New England Journal of Medicine. I believe it showed about what you said, 11 or 12% of patients who have advanced prostate cancer, and this was an unselected for family history patient population, had a pathogenic variant that does have implications. And so when I'm talking to my patients about it, I talk about two things in particular. So one, cascade testing, and two, the availability of treatment for more advanced disease or personalized medicine. So when thinking about cascade testing, patients will say, what does this mean for my family? Why would I want to do that? And if there is a mutation, a germline mutation that predisposes family members to a certain condition that, if detected earlier, would benefit them, of course, the majority of patients are going to say, yes, I want that testing. I want my family member to then get tested if I have this, so that they can then begin screening at an earlier stage and then potentially have better outcomes from their disease. And then two, PARP inhibitors. Are PARP inhibitors being used in Japan, Dr. Sugimoto?
Yes. Now just approved the PARP inhibitor and the NHT. Yeah.
And is that something that's prescribed by urologists or medical oncologists?
Yeah, of course, definitely, mainly the urologist in Japan.
Oh, really? Okay.
Yes.
Great. And
how about in US? Maybe medical oncologist, the prescribe.
Yeah, the medical oncologists are prescribing them, at least in our academic center. I think we're very comfortable now with the oral novel hormonal agents, but then when it comes to chemotherapy or PARP inhibitors or immunotherapy, that is in the realm of medical oncologists.
I see.
And Chad, what about at your center?
Yeah, same. I don't have much experience prescribing it. Obviously, I've seen patients who have been on it, and it's one of the things. I guess fatigue is pretty significant, and asthenia with those agents. But I don't have any prescribing experience with those, and probably because for them to get there to the point where they're going to use a PARP inhibitor, they would have had the genetic testing, which shows like BRCA mutations, and then usually they've already been set down that path by the medical oncologist, so they would be the ones that prescribe it before I would even think about prescribing it. And I think that going back to the germline genetic testing and what we do here, another challenge with our sort of workflow is that a lot of counseling outside of just what to do with the results, has to happen when it comes to genetic testing. And I think, we're probably going to talk about this, but when you have a mutation, it has not just the medical implications, but also sort of work-life implications. You've been diagnosed with, let's say, a BRCA mutation, and your family members, and the question is, how does that impact things like your insurance coverage? Is your premium going to go up because they said now you have a mutation that predisposes you to cancer, and we think that you're going to be a huge cost for us as an insurance company? Then there's the other thing of your job. Let's say you have a very kind of high profile job, and I think in the US here, we've seen certain cases of high impact officials who've had prostate cancer. Imagine if ahead of time somebody knew that one of them had a mutation and they were running for office or something else. I mean, all these things have major implications. And fortunately in the States, they have policies in place. So the Genetic Information Non-Discrimination Act is one of them, or GINA, basically prohibits anybody from firing or changing your compensation or demoting you or making you do a different type of job than what you were hired for because you may have one of these results. But if you think about the potential implications, and a lot of this genetic information can get out there sort of inadvertently, because these tests that you can order, even like 23andMe has some sort of basic level of genetic testing that can then, somehow be relayed to, let's say, a manager, an employer. All these things have major implications.
Yeah, a really important point, and that is something that many patients do ask about. I think there's this fear of discrimination, and fortunately, there are federal protections, like you mentioned, the GINA Act that prevents discrimination, but not for private insurance, and like not kind of across the board. So it's important to understand that and make sure that your patients are understanding that as well. All right, any final thoughts that you want to finish up with? Give one takeaway that you each want to share about managing patients with advanced prostate cancer. Dr. Sugimoto, what do you think is one thing exciting about advanced prostate cancer? I know I'm putting you on the spot here. One good takeaway from for our listeners.
Yeah, we are the scientists, so we have to obey the treat based on the evidence-based, solid evidence. It's very important point. The standard treatment is not always usually introduced in Japan. It's a big problem. So again, we are scientists.
Great, I agree. I always tell my family I'm a scientist.
Yeah.
All right, Chad.
I think the take homes from this, and something that I try to tell my trainees, residents, anybody going into the prostate cancer space, basically it's a complex field, and we just talked about combination therapies, multiple treatment, genetic testing, all these things, and all while we're trying to do surgeries and manage patients. I think how the AUA guidelines has it set up in a nice kind of workflow of, as you mentioned, the disease states. When you think about these patients, try to put them in one of those buckets. And then when it comes to the therapies, which of these disease states is where I use that drug. I think mastering just that sort of general overarching theme will help you to take good care of these patients. And of course, as always, you don't need to do it alone. You have many colleagues in the form of medical oncology, radiation oncology, genetic counseling. So, take your framework and work with each of them inside of their distinct specialties, and we can do a really good job with our patients.
Great. And I will say, I'll put myself on the spot too. There is cause for hope. And just in the past 10 years, the remarkable advances that have occurred in our understanding and the science, we're scientists, the trials that have taken place where we see patients with advanced prostate cancer living longer, doing better, and being able to enjoy their lives is really a cause for hope. And as we continue to collaborate, we continue to do genetic testing, we continue to explore and study new medications and combinations of therapies, I can only assume that it's going to improve. And so, patients who have advanced prostate cancer now may have medications or treatments available to them in 2 years that we're not even fully aware of yet. And so I try and infuse hope into this very special group of patients, because I think that there's so much happening right now. So I want to really thank you guys for your time and your expertise. And I think this was a really informative session on advanced prostate cancer for our JUA and AUA colleagues. Thank you so much.
Thank you.
Thank you.
And for those of you who have participated, please access the course evaluation. You can claim credit and obtain a certificate at auanet.org/university.